Welcome to Module 3, where we will discuss practice standards, licensure topics, and compare the terms telemedicine and telehealth. We will define the acronyms MUA, MUP, and HPSA in the context of telemedicine, and we will describe policies related to telemedicine visits. This module will provide the participant with an overview of medical practices in adherence with Medicare and Medicaid reimbursement policies. The content has been designed for a clinical audience with minimal exposure to telemedicine. According to the American Telemedicine Association, there is no central definition of telehealth, although one might imagine it encompasses the delivery of health services through telecommunication. Most often, telemedicine is strictly defined as three things: synchronous video conferencing, asynchronous store and forward transmission of information, and remote monitoring. Telehealth may encompass this and much more, including a broader array of services and technologies such as artificial intelligence, genomics, virtual reality, education, and clinician consultations and training. Consumer health applications such as mobile health and patient-related social media presence are included in telehealth. These types of technologies are often grouped together under telehealth and referred to as e-health. The American Telemedicine Association is now using these terms interchangeably. Patient geography is very important, so a discussion about population boundaries and health disparities is essential. Two acronyms, MUA and MUP, are frequently used in telemedicine. A medically underserved area, or MUA, exists where there are too few primary care physicians, healthcare providers, dentists, and mental health providers to care for the population. A medically underserved population, or MUP, exists when a vulnerable subgroup of the population faces extreme barriers to accessing care. It is of value to remember both are government-issued designations and carry important weight for telemedicine policies and reimbursement. We will continue more on this topic later. The location and general density of physicians is also interesting to the federal and state government because it is used as a metric to determine reimbursement. The term Health Professional Shortage Area, or HPSA, is used when there is a shortage of providers to care for a population, a specialty, or a facility need. You can see on this map of Texas that we face great shortages of primary care providers throughout the state, especially outside of the greater metropolitan regions. You can find if you are in a health professional shortage area by going to the website listed on the slide. Reimbursement policies through Medicare are rapidly evolving. The years 2018 and 2019 brought sweeping changes to the way this delivery mechanism is reimbursed. The patient's location at the time they see the physician is known as the originating site. This is important because Medicare has historically treated telemedicine almost exclusively as a tool for rural areas. As such, they restricted the areas in which a physician could practice, for the most part, and receive compensation for services. We will see this is changing from only serving patients in health professional shortage areas to a wider definition. It is important to note for Texans, most of the areas outside the major metropolitan cities are health professional shortage areas in need of service. Medicare may still limit who can provide services. These are licensed professionals, which include physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, and certified registered nurse anesthetist. Also included are clinical psychologists and clinical social workers, who notably cannot bill for psychotherapy services that include medical evaluation and management. And lastly, registered dietitians or nutrition professionals. In order to receive reimbursement for services, original Medicare has typically been restrictive about where the patient is immediately located at the time of the visit. For example, the patient must be at one of the following facilities: a physician's office, a hospital, a health clinic, a skilled nursing facility, a mental health center, or a hospital-based renal dialysis center. These environments should ensure to have adequate telecommunication technology to comply with the appropriate standard of care. Starting in 2020, Medicare Advantage has removed these restrictions, allowing the originating site to be the patient's home. In 2019, exceptions were enacted to remove geographic restrictions for the treatment of end-stage renal disease and the treatment of acute stroke, including a mobile stroke unit, and for the treatment of substance use disorder. The exceptions for what are reimbursable and what is not can be confusing, so it's always best to consult the appropriate payer when in doubt. As stated on the prior slide, for end-stage renal disease services, renal dialysis facilities and the home now qualify as eligible originating sites. If the site is the home, an in-person visit is required once a month for the first 3 months and once every 3 months thereafter. A second exception includes acute stroke treatment. For the treatment of acute stroke, a mobile stroke unit is eligible for reimbursement. Additionally, the geographic limitation would not apply for the treatment of acute stroke in any of the eligible originating sites, including mobile stroke units. The final consideration stipulated by Medicare is regarding the treatment of individuals with substance use disorder. This falls under the 2018 Support for Patient and Communities Act, which required CMS to adjust their reimbursement policy of telehealth for treating individuals with SUDs or a co-occurring mental health disorder. Specifically, it removed the originating site requirements for telehealth services on or after July 1, 2019 for any existing Medicare originating sites. The home was made an eligible originating site for the purposes of treating these individuals. As of March the 5th, 2020, due to the novel coronavirus known as COVID-19, Medicare patients may now see their physicians using telemedicine in any geographic area and from a variety of places, including their homes. With this flexibility, it is possible that beneficiaries can receive clinically appropriate services for treatment of COVID-19. The provider must use an interactive audio and video telecommunication system that permits real-time communication between the distant site and patient at the home. Distant site providers who can furnish and get payment for covered telehealth services subject to state law can include physicians, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetist, clinical psychologist, clinical social workers, registered dietitians, and nutrition professionals. It is imperative during this public health emergency that patients avoid travel, when possible, to physicians' offices, to clinics, to hospitals, or other healthcare facilities where they could risk their own or others' exposure to further illness. Accordingly, the Department of Health and Human Services, HHS, is announcing a policy of enforcement discretion for Medicare telehealth services furnished pursuant to the waiver under Section 1135B-8 of the Act. To the extent the waiver requires that the patient have a prior established relationship with a particular practitioner, HHS will not conduct audits to ensure that such a prior relationship existed for claims submitted during this public health emergency. The reimbursement policies for Medicaid typically follow ones for Medicare, but in this case they differ slightly and should be noted. Medicaid draws a line between telemedicine, which is care delivered by a physician, and telehealth, which they describe as care delivered by other licensed providers. Like Medicare, Medicaid requires that the distant site, or where the physician is located, be in Texas, and the physician licensed in Texas. The patient may be treated while they're at home. Additionally, Medicaid is stricter about whom they reimburse. This includes a narrow list of physicians who are enrolled as Texas Medicaid providers, or those working under the supervision and direction of the licensed physician, including physician assistants, nurse practitioners, and clinical nurse specialists. Medicaid reimburses the following modalities: synchronous video conferencing and asynchronous store and forward, with some form of synchronous audio interaction, telephone, or otherwise. This could include delivering diagnostic images or clinical results. In Texas, telehealth services include healthcare services delivered by a licensed health professional through technology. As of September 2019, the following healthcare professionals may deliver services as long as they are enrolled as a Texas Medicaid provider, licensed professional counselors, licensed marriage and family therapists, social workers, psychologists, licensed psychological associates, provisionally licensed psychologists, licensed dietitians, occupational therapists, speech therapists, home health agencies, school health and related services, and postdoctoral psychology fellows and predoctoral psychology interns under a psychologist's supervision. The required documentation that must be maintained is similar to an in-person practice. Medical records must be maintained for all telemedicine medical services. Documentation for a service provided through telemedicine must be the same as for a comparable in-person service. If a patient has a primary care provider who is not the distant site provider, and the patient or their parent or legal guardian provides consent to a release of information, it is Texas law that the distant site provider must forward his or her report to the patient's primary care provider with the following information within 72 hours: a medical record or report with an explanation of the treatment provided and their evaluation, analysis, or diagnosis of the patient. Unless the telemedicine medical services are rendered to a child in a school-based setting, distant site providers of mental health services are not required to provide the patient's primary care provider with a treatment summary. There are certain pieces of documentation you must secure before starting a telemedicine encounter. One of these is informed consent. In general, informed consent should accomplish the following: tell patients how their security and privacy will be protected, tell them of any potential threats, tell them when services may be terminated and referrals made to in-person care, and if applicable, tell them their billing arrangements, such as you will receive one bill from the hospital, one bill from your physician, and one bill from your specialist. In many states, organizations have simply opted to make their informed consent intentionally broad to include telemedicine. In Texas, to comply with state occupational policy, it is advised to have a separate consent for telemedicine services. You can read the specific quote from the Texas Occupational Code on the screen, which details suggested language for telemedicine consent. In cases where state policy or federal policies for telemedicine encounters are unclear, it is always advisable to consult your medical board. They are well versed in all policies and trump any outside recommendations. A few reminders. Your medical board is responsible for establishing medical practice standards. Your medical board issues your license and can discipline you for violations. Not adhering to standards established by your medical board is seen as unprofessional conduct. However, not adhering to a billing standard established by an insurance company will result in a claim denial. In summary, we covered the subtleties of telemedicine and telehealth, and the importance of geographic descriptors, and we reviewed the specific policies related to telemedicine visits in Texas.